Hello everyone, I'm Dr. Moustafa Mahmoud. Obstructive sleep apnea is a common sleep disorder that affects many people. In this video, we will delve into what it entails. Please don't forget to like, share, and subscribe to my YouTube channel for more video updates. Obstructive sleep apnea is characterized by failure of the upper respiratory muscles to keep the upper airway open during sleep. The collapse of the upper respiratory tract in obstructive sleep apnea leads to episodes of apnea, hypopnea, oxygen desaturation, and arousal from sleep. Etiology. Factors that affect the risk of obstructive sleep apnea can be anatomical factors which result in airway restriction, such as micrognathia, retrognathia, and facial elongation, adenoid and tonsillar hypertrophy, and finally, inferior displacement of the hyoid bone. Also, non-anatomical factors increase the risk of obstructive sleep apnea, such as obesity, central fat distribution, and non-modifiable risk factors, including age and male sex. Also, pregnancy and supine position during sleep increase the risk of obstructive sleep apnea. Finally, additional habits and conditions are associated with increased risk of obstructive sleep apnea, such as alcohol use, smoking, drugs that relax muscles as sedatives and hypnotics, endocrine disorders as hypothyroidism, and associated comorbidities such as obesity, hypoventilation syndrome, and congestive heart failure. Pathophysiology of obstructive sleep apnea. Upper airway obstruction during sleep is often due to negative collapsing pressure during inspiration. However, progressive narrowing in the retropharyngeal area during expiration represents important player. Both obesity through fat deposition in the neck and craniofacial abnormalities play important role in the pathogenesis of obstructive sleep apnea through increasing extraluminal pharyngeal pressure and increasing the risk of pharyngeal collapse. In patients with obstructive sleep apnea, upper airway obstruction can occur in both non-rapid eye movement and rapid eye movement sleep. Due to decline in the activity of the upper airway dilator muscles such as genioglossus and tensor palatini, this decline in the activity is associated with pharyngeal collapse and obstructive sleep apnea. Once airway obstruction has occurred, the ventilation is reduced and blood gas changes to stimulate respiratory effort and upper airway dilator muscles to reopen the airway. But cannot until respiratory effort reaches a threshold that induces arousal from sleep. Following arousal, marked activation of the upper airway dilator muscles, which reopens the airway and allowing for hyperventilation to occur. Hyperventilation reduces the respiratory drive, secondary to hypocarbia, with recurrent airway obstruction on resumption of sleep. Diagnosis of obstructive sleep apnea. Patients with obstructive sleep apnea usually present with excessive daytime sleepiness, while bed partner will observe loud snoring, gasping and choking, breathing cessation. Also, patients with obstructive sleep apnea may suffer from daytime fatigue, morning headache, insomnia, and nocturia. On examination of patients with obstructive sleep apnea, obesity is the most common finding. Other findings are neck circumference more than 43 centimeter in men and more than 40.5 centimeter in women, narrowing of the lateral airway walls, grade 3 or 4 enlarged tonsils, crowded oropharynx with increased Mallampati score, high arched palate, craniofacial abnormalities such as retrognathia or micrognathia. Also, patients with obstructive sleep apnea can be presented with manifestations of comorbidities or complications such as high blood pressure, pulmonary hypertension, heart failure, diabetes, atrial fibrillation, stroke, dyslipidemia, and myocardial infarction. The two-bank questionnaire is an easy tool to identify people who may have obstructive sleep apnea. The questionnaire consists of 8 yes or no questions based on major risk factors of obstructive sleep apnea. The name Stop Bank is acronym for the first letters of each symptom or sign often associated with obstructive sleep apnea. We asked if there is snoring loudly, tiredness during daytime, observed apneas by the partner, blood pressure if high, body mass index if more than 35, age more than 50 years, neck circumference more than 40 centimeter, and gender of male. The presence of 3 yes answers or more is considered a high risk for obstructive sleep apnea. Evaluation. Polysomnography in attended setting has been used as a standard for diagnosis of obstructive sleep apnea. Polysomnography measures several sleep variables, one of which is apnea-hypopnea index. Apnea-hypopnea index is defined as sum of apneas and hypopneas per hours of sleep. Type 1 polysomnography study refers to attended laboratory-based study, which requires multiple physiologic variables to be measured. Signals routinely recorded in type 1 polysomnography study includes airflow signals, respiratory effort signals, oxygen saturation, electroechocardiogram, electromyogram, electrocardiography, electroencephalogram, and snoring signals. Hypopnea is defined as a reduction in the airflow of at least 30% for 10 seconds or more, with at least 4% oxygen desaturation in Medicare criteria or 3% oxygen desaturation or arousal in American Academy of Sleep Medicine criteria. On the other hand, apnea is defined as a reduction of 90% or more of airflow compared to baseline airflow for 10 seconds or more. The following polysomnography findings are characteristics of obstructive sleep apnea. Apnea occurs in presence of respiratory effort. Apnea lasting more than or equal to 10 seconds. Apnea most commonly occurring during rapid eye movement sleep. Combination of apnea and hypopneas may occur. And at the termination of apneic episodes, arousals may disrupt sleep. It is normal to have less than 5 apneas or hypopneas per hour of sleep. But if 5 to 15, it is considered mild, and 15 to 30, it is moderate, and if more than 30, it is considered severe sleep apnea. Treatment and management of obstructive sleep apnea. The treatment of obstructive sleep apnea should be individualized according to disease severity and patient preferences. Lifestyle and treatment of the underlying medical conditions are the first approach. Through weight loss, avoiding alcohol and smoking, avoiding sedative drugs before sleep, and avoiding sleeping on supine position but to sleep on the side position. Second approach is the positive airway pressure therapy, and oral appliances represent the third approach. While surgical correction of the upper airway is the last approach for treatment of obstructive sleep apnea. CPAP therapy is the standard treatment option for patients with obstructive sleep apnea. Nasal CPAP delivers constant level of pressure greater than the atmospheric pressure to the upper airways, which helps to prevent upper airway collapse during sleep. Patients with apnea hypopnea index greater than or equal to 15 are considered candidates for CPAP therapy regardless of their symptom. While patients with apnea hypopnea index between 5 and 14.9, CPAP therapy is indicated when obstructive sleep apnea associated with excessive daytime sleepiness, hypertension, or cardiovascular disease. BiPAP generally used when patient cannot tolerate high CPAP pressures or in cases of failure of CPAP therapy. BiPAP delivers two different pressures during respiratory cycle. High inspiratory pressure, IPAP, to eliminate hypopneas, and lower expiratory pressure, EPAP, to eliminate apneas. CPAP and BiPAP pressures are manually titrated during polysomnography to determine the optimal pressure levels for elimination of obstructive respiratory events as apneas, hypopneas, respiratory-related arousals, and snoring. Oral appliances are prosthetic materials that act when applied in mouth by pulling the tongue forward or moving the mandible and soft palate anteriorly to enlarge the posterior air space. It can be used in patients with mild to moderate obstructive sleep apnea, especially those who are unwilling to use CPAP. Surgical treatment of obstructive sleep apnea is indicated in patients with mild obstructive sleep apnea if medical therapy failed or not accepted by the patient, which include uvulopalatopharyngoplasty, where surgical removal of the uvula and tissue from soft palate increases more space in the oropharynx. Second surgery is maxillomandibular advancement, where upper and lower jaws to be detached and surgically advanced anteriorly to increase the space in the oropharynx. Here we come to the end of our lecture. Till we see you again in the next video. Thank you for watching and goodbye.